Hello everyone, Arnaud de la Fouchardière from Lyon here. A while ago, I was asked by Olga to make a video for Ukraine about the molecular classification of melanocytic tumors. So I finally found the time to make this video. I hope you would enjoy the content. So this talk is about the molecular classification of melanocytic proliferations. And this has become really a part of molecular pathology with an integrative analysis, meaning we are going to combine all the data that comes from embryogenesis, clinical and dermoscopic features, everything that is under the microscope about the morphology, the immunophenotype, and all the genomic data we can have from sequencing, mutation status, methylation analysis, and of course, it's going to be very important to include the clinical evolution of the patients. So in the WHO in 2018, there were 8 classes of cutaneous melanocytic tumors that were described. And this is a multidimensional classification. And the first dimension is UV exposure. So UV exposure can be chronic sun damage, what we call non-chronic sun damage, which is sunburns, and areas that are sheltered from the sun. So the first class is non-chronic sun damage melanoma, arising from areas where a patient had sunburns. Most of these cases are going to be superficial spreading melanoma subtype. And in these, we have the ABCDE clinical presentation. And most of the cases will have a nevus that you can see here. They have pagetoid features with large pigmented melanocytes. And most of the time, we will find a BRAF mutation or NRAS mutation. But not all cases are SSM. And there's also nevoid melanoma subtype, which is rare. These usually have more NRAS than BRAF mutations. And also the nested melanoma subtype, which is a slow growing atypical lesion that is also part of maybe nevoid cytomorphology. The second class is chronic sun damaged melanoma, which means there is high tumor mutation burden. Usually the prototype is lentigo maligna melanoma. These arise in areas with chronic sun damage. We have mainly a lentiginous junctional component with extension to the hair follicles, and these are large and slow growing lesions that can eventually become nodular. And also chronic sun damage is the very rare desmoplastic melanoma. These usually are unpigmented, very difficult to suspect from the clinical presentation, and genetically they can have NF1 mutations. So the second dimension is topography, and the WHO includes the acral and mucosal melanoma. These are very rare subtypes, and these are usually in the sun shielded areas. The third dimension is the clinical setting related to the presence of a large congenital or a blue nevus. Especially this class 8 is about the early transformation in children of large type of melanoma, which can be present in the central nervous system. So usually you have this large type of nevus that can transform into a melanoma that can be a deep type of invasive nodule, like in this case. And most of the time we have NRAS exon 3 mutations. And for the blue, it's a completely different disease. We have the blue type of melanoma arising from a blue nevus, and these have specific genetic alterations. Another group is the cytomorphology, which is represented by the Spitz subgroup, and Spitz cytomorphology is usually a junctional hyperplasia with nests in the junction in this pseudoepitheliomatous hyperplasia, and usually we have large spindled and epithelioid melanocytes. And the last dimension is the genetics, which is both described as which are the drivers in this first row and which are the passenger anomalies that lead to transformation, sometimes from a nevus to a melanoma or progression to more aggressive tumors. Regarding genetic or melanocytic tumors, there is two areas, both what is inherited from your parents with germline mutations and what is acquired often through somatic mutations. So regarding the risk of a tumor predisposition syndrome that will create a melanoma, around 7% of melanomas are thought to arise in patients who have either a personal or familial history of melanoma or other cancers. The most frequent anomaly is CDKN2A germline mutation, also known as BK mold syndrome. All the other anomalies are a lot less frequent. So CDK4 is very rare, BAP1 germline mutations, MITF, and recently described sheltering complex, and also what is xeroderma pigmentosum and MC1R variants. So these syndromes can involve different type of tumors depending on which anomaly, and this can lead to the patient having a clinical surveillance program. Let's talk about the embryology of melanocytes. So usually in anomalies, there is post-zygotic mutations in the neural crest melanoblast, and after there is a migration program from the neural crest to the skin or other areas. So in the normal melanocyte, it starts by a dorsolateral migration that makes the normal melanocytes inside the skin and also in the hair shaft. And the second is a ventral migration that follows the Schwannian nerve formation. And so we have in the dorsolateral melanocytes in the epidermis, but also in the hair bulbs and in the sweat glands. And this could be different type of melanocytes, possibly leading to different type of melanomas. So when there's an anomaly in a melanoblast, like a mutation, then this mutation is found in the melanocyte and can give rise to a cutaneous mosaicism. So that means only the melanocyte has the mutation, where all the keratinocytes surrounding do not have it. So this is very frequent in the group of Spitz tumors, especially with HRAS mutations, and has been shown in the model of nevus spilus. So we have a very limited area where the skin is pigmented, and only in that area there can arise during the life different tumors. For example, in this child, it was half of the face. So the spot is not always visible. The background patch is not always visible. And we have proven that this is also true for fusions such as GOPC or ROS1 fusion with this patch and multiple tumors. So we have then the example of the multiplication of melanoblast in the neural crest, and this leads to a nevus. Usually we have, if it's a BRAF mutation, it would look like a common nevus like this. It can also be a large type of congenital nevus, and also can be a blue type of nevus with different type of anomalies such as GNAQ or GNA11 mutations. So the WHO has really made clear that there is the possibility from the progression from a nevus to melanoma to have intermediate stages that is called low-grade dysplasia melanocytoma and high-grade dysplasia melanocytoma. And there are some examples where we have on the same slide all the different phases from the nevus, the intermediate steps to the melanoma that are visible, to really prove that this is not only a theoretic concept. So basically there are three big families in which we have this nevus to melanoma progression, which is the blue family. The most frequent is the common nevus family that leads to SSM, and the Spitz nevus that leads to Spitz melanoma, starting with a nevus spidus like I've shown you before. So the first step in the group is going to be really early lesions like dermal melanocytosis, a nevus spidus, or just a common nevus. And these have specific and clinical features and some specific morphological features described in the WHO book. And then only a subgroup of these aspects can progress to the intermediate tumors. And this needs, I think, additional molecular anomalies to become a Spitz nevus, dendritic cellular blue nevus. And these also have specific morphologic features described in the WHO. So example of low grade in the common group would be like a clonal nevus. So if we look here at this mosaic of image, all of them have a BRAF V600E mutation background, but they all look different, meaning that that mutation by itself is not going to be only responsible for the morphology. It's going to be all the secondary events that can drive either morphology or a degree of pigmentation. So let's look at the common group, the most frequent group, in which we have this progression that usually starts as a clonal biphenotypic morphology. And there are three examples, which is the BAP1 inactivated melanocytoma. We have a nevus, and here is the clone. Or the Wnt activated melanocytoma, what was called DPN, where we also have this hyperpigmented area arising from a nevus. And we have pigmented epithelial melanocytoma that appears through the inactivation of this gene PRKA-R1 alpha, and would give a rise to, again, a hyperpigmented area within a nevus. So we have three different types of morphology. They are not all the same. And again, this is described in the book. And independently, these three types of intermediate tumors can progress eventually towards melanoma, which will be specific subtypes of melanoma arising from a BAP1 inactivated melanocytoma. Plexiform melanoma is the name of the progression from Wnt activated melanocytoma, and malignant PEM from PEM. And here are some examples of these three tumors. Moving now to the third step of progression, which is intermediate grade tumors that are high-grade melanocytomas. We know that only a subset of the secondary step can progress towards this. Usually this is a transient stage. They have specific names. Usually they're clinically atypical, a presentation that is worrisome. They have a high density in the dermis and other atypical features. Currently, there's not a very good description of all the characteristics of these tumors, and it's an area of work in progress. And we know that most of them will probably move on to the melanoma stage, which is the last stage of progression. So these are different diseases, like blue type melanoma is very different from SSM, and it's completely different also from a Spitz melanoma. So if we look at the most frequent group, which is the common nevus with BRAF and NRAS mutated background, now we know there is a cascade of progression of different genetic anomalies from the nevus towards the melanoma and the invasive, with all these events that arise in a sort of progression model. So here are some examples: start and then loss of CDKN2A, which codes for P16, a loss of P10, and these other mutants are in the high grade already invasive melanomas. So if we take an example of a very large tumor on the back, and if we look on one side, we will have this proliferation that is usually junctional with small melanocytes, and this is a quite high density, and we can discuss the high or to low grade dysplasia. Still in the same tumor, if we look somewhere else, we see that the density is raising with now confluent nests, and there is some modification of the architecture of the epidermis, and starts to appear a lot of inflammation. Probably this could be a really precursor or melanoma in situ stage. And lastly, we also see, still in the same slide, areas of invasive melanoma, clearly invasive, with this precursor on the side. So what we know is that if this lesion here is left, it can progress to a melanoma, and we don't need to spend a lot of time to discuss the degree of dysplasia, but we just have to make sure they are completely removed. But we know that not all melanomas arise from a nevus, and there is sometimes a direct transformation from a normal melanocyte to an in situ melanoma. And there are some theory which is called genomic hailstorm that has been described for acral melanomas. And it shows that on 4 different chromosomes, 5, 11, 12, and 22, there are specific areas that can be amplified in some of these cases. And this is probably the initial event inside these tumors. This can lead to some instability and have some appearance of secondary genomic drivers that appear with oncogenesis in the end. And if you look at these melanomas that arise from normal melanocyte, they always start by in situ stage, which can be quite long, especially for acrolentiginous melanoma or lentigo malignant melanomas. They can have very large tumors, which we can be stay for more than several years before becoming invasive. And after some time, of course, we will have invasive melanoma in these different subtypes. So desmoplastic melanoma is kind of a different disease that also is associated with high-grade degree of UV exposure. So what about nodular melanoma? It's not a category of melanoma because I've shown you it's not present. It's not because there is a nodule that we have to call things a nodular melanoma. And in the WHO book, here is the description. It is likely that nodular melanomas are accelerated evolutionary trajectories of different subtypes rather than a subtype per se with a distinct genomic profile. And mainly the pathway are going to be pathway 1, 2, 5, and 6. And regarding primary dermal melanoma, this is something extremely rare, and we have to have very important criteria to make sure it's not a relapse, it's not a metastasis, for example. So molecular pathology of melanocytic tumors is really identifying the right color from a known palette of lesions. We're going to see in which family we are and try to find out how far we have progressed from the early stages to the late stage melanoma. And what is important is that there is different prognosis for each color, especially for the Spitz group, where they have a very good overall prognosis. And it's important to identify this subgroup for not having too much overtreatment. I hope you enjoyed this video, and you can follow me on social media about the molecular pathology of melanocytic tumors. Thank you again.